Good afternoon, everyone. My name is Kyung Park, and it's a great honor to present in this such a wonderful event in this beautiful city of Gan. And I'd like to thank all of my colleagues who competed with me in the MEGA'MIND Final League, and also MEGAGEN and MINEG for organizing this such a wonderful event. So I'm a prosthodontist from South Korea, and also a husband and a medical officer in the Korean Army. So some of you might know, in my country of Korea, every man has to serve for the military for a certain period of time. So I'm the only person in this room who's serving for the military. So my topic today is about digital, a key paradigm in today's dentistry. But we all know that digital is not perfect yet, and we are in the transitional period. So that is why many clinics still rely on the combination of the conventional and the digital. So I felt the need to clarify the current status of the digital prosthetic workflow in an evidence-based manner. And as you've listened, compared to the previous presentations of the MEGA'MIND colleagues, my presentation will be a little more conservative, based on the basics and more of the fundamentals and the evidences. So please adhere to this. So today I'd like to discuss two aspects. First, advantages and challenges of the current digital prosthetic workflow. And second, what we should consider to minimize the errors in current digital prosthetic fabrication. So starting with the advantages and the challenges, we all know that digital simplifies lab workflows and reduces the shared time. And this is already accumulated in so many studies, as this systematic review shows. So there's nothing much to talk about this. And I think another major advantage of the digital prosthetic workflow is that more comprehensive diagnosis in a restoration-driven manner has become possible. And in my opinion, the development of the 3D facial scan has played a major role in this, in both aesthetic aspect and occlusal aspect. So if you look at the aesthetic aspect, when we design the optimal smile for patients, it is clear that we should consider their asymmetrical facial features. And some studies recently have given us some guidelines on this. So when setting the dental midline, it should follow the patient's asymmetric facial flow curve. And when setting the anterior transverse occlusal plane, it has to be parallel, following the commensurate lip curve of the patient. So this is where the digital comes in, because by using the 3D facial scans, prosthetic design following the patient's facial features becomes possible. Another is the occlusal utility, and recent studies supports that using the anatomic landmarks from the 3D facial scans are reliable enough for setting the optimal occlusal plane for oral rehabilitation cases. Or if faceplate mounting is needed for some cases, we could use some posterior anatomic reference points from the facial scans. So for the occlusal plane, we usually use the Alatrogus line or the Camper's plane. And for the arbitrary mounting, we could use some known reference points from the literature, such as the Bayron point, set from the posterior margin of the ear tragus, or the Bergstrom's point, set from the Porion. So this is a case example using some digital diagnostic tools. Now, this patient visited our clinic hoping for overall prosthetic rehabilitation. And by the looks of the initial panoramic view, there were some hopeless teeth and implants on the posterior area. And by the looks of the intraoral photo on the anterior area, we could see some severe attrition, anterior crossbite, loss of posterior support, which would indicate that space for aesthetic restoration was insufficient. So this means that full mouth rehabilitation is needed for the treatment. So first, we had to secure the space for aesthetic restoration, so vertical dimension had to be elevated around 3 millimeters, and it was taken using analog method. And this newly established jaw relationship was digitized and superimposed to the facial scans to form the virtual patient. So for the next step, virtual faceplate transfer was done, and as I have mentioned before, I used the Bayron point, 30 millimeter anterior from the posterior margin of the ear tragus as the arbitrary hinge axis. And for the occlusal plane, electrogoose line, retromolar pad, and the average value of the anterior tooth exposure for the elder people were used as the reference for the setting. And based on the setting, diagnostic wax-up was done with the 3D printed provisional crowns and dentures. For the occlusal scheme, mutually protected occlusion was set while checking the facial aesthetics so that the dental midline follows the patient's banana-shaped facial flow curve, and so that the anterior occlusal plane should blend with the commissural lip line. So based on the wax-up, implant padding was done, leading to the guided implant surgery with the initial mouth preparation. And at this point, immediate provisional restorations were delivered with canine guidance in check. And with the virtual facebone mounting, not much adjustment was needed. So after waiting for 10 weeks, we switched to the second provisional restorations and checking all the tissues to make sure that we were now ready to fabricate the final prosthesis. So for the next step, final impression was taken in an abutment level by the analog methods. And with the cross-mounting casts were all digitized in a dual scanning manner so that we could design the final prosthesis, which follows the morphology of the provisional crowns. So these are the finally fabricated zirconia crowns along with the final dentures and delivered to the patient. And this photo was actually taken 1 year after the delivery for the follow-up. And all the soft tissues, the prosthesis, the occlusal scheme, and the bones surrounding the implants were all stayed without any problems. So it was a brief case example, but a good example utilizing the digital diagnosis. So using the digital tools will allow a more comprehensive provisionalization in many aspects, which will allow more optimal prosthetic results. So we've seen the advantages of the digital tools, but the challenges, especially for implant cases, is that for full digital prosthetic workflows, their indications and accuracy is still unclear according to the literatures. And for us to fabricate digital prosthesis digitally, accurate digital impressions and accurate digitally fabricated casts should be mandatory. So let us see what the current studies say about this. The most current studies say that for digital implant impressions, in vitro studies show that their accuracy is already superior compared to the conventional impressions. But we should keep in mind that actual intraoral conditions would undermine the actual scanning accuracy. So that is why we have to pay attention to some in vivo studies recently. And according to these studies, the digital impression accuracy is clinically acceptable limited for short span cases, such as single case or anterior partial arch case, or partial arch cases with some distal free end cases. But it is still reported to be unclear for long arch or full arch cases. Now, don't get me wrong, because it doesn't mean that we cannot use full digital workflow in full arch cases. It is what the literature says. So it's up to you to interpret these results. And for full arch cases, still unclear despite the use of various auxiliary scan aids. But on the bright side, the accuracy of the digitally fabricated prosthetic casts seem to report clinically acceptable accuracy regardless of the range of edentulism. So combining the evidences, it seems that the ideal indication for full digital prosthetic workflow is limited for short partial arch cases. And I'm saying it again, it's up to you to interpret these results. So what does this mean? It means that digital is not perfect, so we have to take detailed care in every fundamental step for digital implant prosthetic fabrication. So let's take a look at what we should consider on this. Now, this is a case example using a full digital prosthetic workflow and also a story of a firefighter who suffered from a dental trauma with spontaneous pain and unaesthetic appearance on maxillary central incisors. And by the looks of the initial examination, the 2 teeth seemed hopeless to be saved and needed for some implantation. So careful planning was done regarding the facial aesthetics, to design the surgical guides for implant surgery. And the surgery was done, but the initial stability was not reported to be enough, so we had to wait for several weeks for the conventional loading. And after waiting for some weeks, digital scan body impression was taken. And this is probably the most important step in fabricating the prosthesis with digital methods. So what are the factors for successful scan body impressions? I'd like to talk about some fundamentals, maybe a little bit boring, but I think it's very important. So 3 categories: scanning condition, scanning strategy, and scan body choice. So let's look at the evidences. The scanning condition, the ambient lighting conditions would be important. And according to the researchers, illumination around 1,000 lux seems to provide optimal accuracy regardless of the scanner types. And it seems that compared to the triangulation system scanners, confocal scanners are less affected by the lighting conditions. So for your everyday daily practice, this may be one of the criteria for choosing the optimal scanner. And the ambient temperature. The changes in the surrounding temperatures of the scanning environment will undermine the scanning accuracy. So it would be advisable to keep the surrounding temperatures stable enough. And of course, the scan surfaces have to be dried enough to minimize the reflections and to maximize the scanning accuracy. Basic stuff, but very important. And next is the scanning strategy. About the optimal scanning distance, it is not still clear, but evidences say that too short scanning distances will cause oversaturation of the stitching of the data and may cause distortion when they are converted to the mesh data. But if it is too far, it may undermine the ability to capture the reflected light from the surfaces. So we should keep this in mind. And the scanning pattern, it will differ upon the scanner types and the scanning situation, whether it's mostly dentate or whether it's mostly edentulous with implants. And various studies have conducted researches on each clinical situations. So I concluded that it would be the best to follow the clinical manufacturer's recommendations or these evidences for choosing the most optimal scanning pattern. And finally, the scan body choice. In clinics, we usually use a PIC scan body or the titanium scan body. And for the PIC scan body, they are easily scannable since there's no surface reflections. But the problem is that only single use is recommended. And this is due to some deformation issues, such as repeated sterilization after use, or if excess torque is applied when the scanning is done. So for multiple uses, titanium may be the better choice, since it has more stable thermomechanical property, but the problem is that it has some reflection issues. So we should keep the pros and cons of each materials in mind when choosing the most optimal scan body. In the geometry, no straight consensus, but majority of the studies agree on one fact that excess sharp or complex structures of the scan body will undermine the scanning accuracy, and this is because these structures may get distorted when converted to the mesh files. So it may cause trouble in accurate matching with the scan body library. And finally, the dimension. Not much studies about the diameter, but there seems to be some certain pattern associated with the supramucosal height. If the surrounding tissues are mostly dentate, short length may be more preferred, but if it is mostly edentulous, longer length may be preferred. But it seems that between 3 to 7 millimeters of the supramucosal height, does not seem to be any significant difference. So what I want to say is that the optimal scanning strategy has to be crafted based upon the evidences. Maybe a little too conservative, but I think it's the safe way. For this case, I used a PIC scan body for single use, which was cylinder-shaped with only 1 or 2 decut area for matching. And to prevent the deformation of the scan body, hand torque was applied. And for this case, scanning direction was set from occlusal, palatal to buccal direction with zigzag pattern on the scan body area. So after scanning, interim PMMA crowns were designed and delivered to the patient, but we could still see some black triangle areas along with some uneven gingival lines, so additional recontouring was needed. to improve the pink aesthetics. And at this point, we could see some intact gingival architecture without any inflammation. So this meant that we were now ready to fabricate the final prosthesis. So for the next step, digital allows a more simplified transfer of the subgingival contour because only the scanning and the merging, assembling of the data is needed on the single CAD software. So by doing this process, we could design the final prosthesis more easily, respecting the contour of the interim crowns. And after that, the customized abutments and the final crown was fabricated. And for this case, I did not use any 3D printed cast. So another question. Is using the cast-free workflow without the 3D printed cast commendable for daily practice? There's no straight answer for this, actually. But according to the evidences, cast-free workflow may produce better prosthetic fit for very short span cases because they exclude the errors that may be produced by the 3D printed cast. But the problem is that we would all know that pre-adjustment on the model is not possible, which may cause longer chairside adjustment time. So for longer arch cases, these casts may still be mandatory. So regarding this, customized abutments were delivered, and I used the PMMA prototype so that I could prevent the misfit caused by the rotational errors in the internal hexagonal screw channels. And checking that everything's fine, zirconia crown was delivered with the patient recovering his smile. And after 1 year, all the tissues and the crowns were all maintained without any problems. So overall, digital smile recovery done without any problems. So it's time to wrap up our presentation. Now, digital allows a more comprehensive diagnosis in a restoration-driven manner, as I mentioned. And its indication using the full digital prosthetic workflow is expanding every day, but still unclear in long-term evidences on long and full arch implant cases. I think the most important thing is that we should keep in mind that digital itself is not the master key. So every clinical step has to be done with detailed care, following the fundamentals and the evidences. And most importantly, we should update our latest evidences and clinical perspectives about the digital issues. So these are the references. And thank you for listening.